So I want you to picture the most extreme, violent physiological transition a human body can possibly endure.
Oh, yeah. It really is completely wild when you think about it.
Right. I mean, for 9 months, this body has lived in this warm, fluid-filled aquatic environment.
Perfectly temperature controlled.
Exactly. And its lungs have never taken a breath of air. They're completely collapsed, just filled with amniotic fluid.
And the digestive tract has never processed a single meal.
Nothing. It doesn't even oxygenate its own blood. There's a completely separate organ, the placenta, doing literally all the heavy lifting, pumping oxygen-rich blood through this temporary umbilical lifeline.
Yeah, it's a total bypass system.
And then in a matter of seconds, everything changes. The environment drops by 20 degrees, the umbilical cord is clamped, the oxygen supply is suddenly just abruptly cut off.
The carbon dioxide in the blood spikes immediately.
Right, and the brain panics. And in that terrifying moment of hypoxia, the diaphragm violently contracts, the chest wall expands, and the lungs suck in air for the very first time.
Which pushes all that fluid out of the alveoli.
Exactly, creating this massive cascade of pressure changes that slams shut the bypass valves in the heart, and blood suddenly rushes into the newly expanded lungs.
I mean, it is nothing short of a biological miracle that it works at all.
It really is.
The sequence of events that has to execute perfectly in those first 60 seconds of extrauterine life is staggering.
Because if it doesn't...
Right. If a single pressure valve fails to close, or, if the lung tissue doesn't secrete the exact right chemical surfactant to keep the air sacs open, the entire system crashes.
And that is exactly where you come in. You, the listener. Because today, you are stepping into a new role.
A very high-stakes role.
Yeah. Imagine it is your very first day as a medical student on rotation in the neonatal intensive care unit and the newborn nursery.
You've scrubbed in, your hands are washed.
You've got your pediatric stethoscope draped around your neck, and you are standing in front of a radiant warmer. Under that heat lamp is a human being who has been in the outside world for exactly 2 hours.
And they can't tell you where it hurts.
No, they can't follow instructions. They are a complete physiological mystery.
And as your attending neonatologist for these rounds, it's my job to teach you how to solve that mystery.
Which is what this deep dive is all about.
Yeah, you are going to learn how to read the physical signs of a body that is actively re-engineering itself in real time.
Okay, so let's unpack this, because we have an incredibly intimidating stack of clinical protocols, guidelines, and nursing assessments to get through today.
We really do.
We're synthesizing the classic Ballard score parameters, Stanford Medicine's newborn guidelines, the Newborn Screening Ontario protocols for congenital heart disease, and just a massive trove of Stat Pearl's clinical reviews.
A lot of material.
It is, but our mission is to decode exactly how to examine a baby from head to toe in those crucial first 24 to 48 hours.
Right, breaking down step by step what we actually do.
Exactly. So by the end of this deep dive, you'll know exactly what a neonatologist is looking for, and more importantly, the underlying biology of why we are looking for it.
And I think the very first thing you need to learn on this rotation is that your standard approach to a physical exam is entirely useless here.
Wait, really? Entirely useless?
Completely. If you approach a newborn the way you approach a cooperative adult in a clinic, you will completely sabotage your own assessment.
Because you can't just, walk up and stick a cold stethoscope on their chest.
Exactly.
The guidelines establish a very strict golden rule for the neonatal exam, which is observe before touching.
Yes, observe before touching. It's critical.
It specifically dictates this sequence. You look, you inspect the environment, you check the skin, you do the cardiovascular and respiratory exam quietly,
Really calm.
right then the abdomen, and you absolutely must save the musculoskeletal and neurological exams like the hip checks and the reflexes for the very end.
Because think about the autonomic nervous system of a 2-hour-old infant. It is highly reactive.
So if you poke them right away,
If you start by testing their startle reflex or, manipulating their hip joints, they are going to scream.
makes sense.
And the moment that baby starts crying, they enter sympathetic overdrive. Their heart rate spikes to 180.
Wow.
Their breathing becomes erratic and shallow. Their abdominal muscles tense up like a board, making it impossible to feel their liver or spleen.
So you're basically flying blind at that point.
Exactly. Their skin gets flushed, masking any subtle cyanosis or pallor. You've just destroyed the baseline physiological data you need to figure out if they're actually healthy.
So it's really about preserving the natural resting state of the machine.
Precisely.
I imagine the physical environment plays into that baseline as well, right? Because the sources are adamant that the exam happens between feeds when the baby is calm but alert, and that they must be kept warm.
Oh, thermoregulation is a massive vulnerability for newborns.
Because they're so small.
Well, yeah, they have a high surface area to body mass ratio, meaning they leak heat rapidly into the environment.
Oh, I see.
And unlike you or me, newborns cannot shiver to generate heat.
Really? I didn't know that.
Yeah, they rely entirely on metabolizing a specialized tissue called brown fat.
Okay, brown fat.
So if you leave them naked on a cold table, they will burn through their brown fat reserves, their blood sugar will plummet, and they will go into respiratory distress simply because they are cold.
Just from being cold. That's terrifying.
It is. So we examine them partially clothed, under a warmer, exposing only the area we are actively assessing.
Right. And as a medical student, you're not just managing the baby's stress, right? You're managing the room.
Oh, absolutely. The parents.
You are standing there with parents who have just gone through an exhausting labor and are now intensely watching every single move you make.
That human element is non-negotiable.
Because they're terrified too.
Right. If you furrow your brow and silently stare at a baby's chest for 2 minutes, the parents will assume their child is in heart failure.
So you have to talk them through it.
You have to narrate your findings proactively. You introduce yourself gently, and if you feel a perfectly normal, benign bump on the baby's skull, you say, "I'm feeling a small, soft area of swelling here," which is completely normal.
Normal from the birth process.
Exactly, and you assure them it will go away in a few days. You do this before the mother has a chance to panic that it's a skull fracture.
That is such a good clinical tip. Okay, that brings us to the very first piece of data we collect, literally within 60 seconds of birth. The APGAR score.
The classic APGAR.
Right. The sources note this is taken at 1 minute, 5 minutes, and occasionally 10 minutes.
Dr. Virginia Apgar designed this back in 1952, and it remains the universal language of neonatal transition.
And it's not a predictor of long-term intelligence or health.
No, not at all. It is a rapid-fire, real-time assessment of whether this baby is surviving the immediate transition from umbilical oxygen to lung oxygen.
It's an incredibly elegant system. 5 parameters scored 0, 1, or 2.
Simple but effective.
Let's look at the underlying physiology of each. First is heart rate. A 0 is absent. A 1 is less than 100 beats per minute. And a 2 is greater than 100.
Right.
Now, wait. For an adult, a resting heart rate over 100 is tachycardia. It's a huge problem. Why is it the golden standard for a newborn?
It comes down to cardiac output, which is the total volume of blood pumped in a minute.
Okay, cardiac output.
Cardiac output equals stroke volume. That's the amount pumped per beat multiplied by the heart rate.
Right, basic math.
But a newborn's heart is tiny and the muscle fibers are incredibly stiff.
Oh, so they can't expand much.
Exactly. Their stroke volume is essentially fixed. They cannot stretch their heart to pump a huge volume of blood with a single squeeze like an athlete can.
So the only way to pump more blood
Is to pump faster. It is the only physiological mechanism they have to increase their cardiac output and deliver enough oxygen to their brain.
Wow, so if a newborn's heart rate drops below 100, they are failing to oxygenate.
Actively failing, yes.
That makes perfect sense. Next is respiratory effort. 0 is absent. 1 is irregular, weak gasping. 2 is a robust, angry cry.
Because a crying baby is a breathing baby.
Simple as that. Then we have muscle tone.
Right.
0 is completely limp and flaccid. 1 is some flexion of the arms and legs. 2 is tight, active motion.
And muscle tone is a direct window into the central nervous system.
How so?
A healthy term baby is born with high flexor tone.
Yeah.
They want to be curled up in the fetal position.
Right, drawn in tightly.
If the brain is severely deprived of oxygen, one of the first things it does is shut down non-essential motor outputs
To save energy.
to save oxygen for the brainstem. So a floppy, limp baby is a brain that is actively screaming for oxygen.
That is a stark visual. Then there is reflex irritability. 0 is no response to stimulation. 1 is a weak grimace. 2 is an active cough, sneeze, or pulling away when you suction their airway or flick the soles of their feet.
Checking their basic wiring.
Right. And finally, color. 0 is pale or blue all over. 1 is a pink body, but blue hands and feet, which the notes call acrocyanosis, and 2 is completely pink.
Let's contextualize the color score, though.
Okay,
It is incredibly rare for a baby to get a 2 for color at the 1-minute mark.
because they're usually still a bit blue.
Yeah, because of the massive circulatory changes happening, their peripheral blood vessels are tightly constricted, shunting all the highly oxygenated blood to the brain and heart.
Oh, so the hands and feet stay blue for several hours, sometimes days.
Exactly. Acrocyanosis is a normal, expected finding. We're really looking out for central cyanosis.
Which is what?
Blueness around the lips, tongue, and the core of the trunk. That's a huge red flag.
Okay, so you tally those up. A perfect score is 10. The sources state that 7 to 10 means the transition is satisfactory.
Which is where we want them.
A score of 4 to 6 indicates moderate distress, maybe requiring some stimulation or a mask to give them positive pressure breaths. And 0 to 3 is a full-blown emergency resuscitation.
Code blue situation, yeah.
But I want to push back on the sequence for a moment.
Sure.
You mentioned earlier that before we touch the baby to do these deep assessments, we have to observe.
Yes, the look phase.
If you're standing at the warmer, your hands in your pockets, how are you actually extracting clinical data? Is it like a mechanic listening to an engine idle before popping the hood?
That is precisely the right mindset.
Really?
If we connect this to the bigger picture, a skilled neonatologist gathers 80% of their diagnostic data before the stethoscope ever touches the skin.
80%, just from looking.
Just from looking. When I stand at that warmer, I am watching the engine run. I'm looking at the symmetry of their movement.
Like checking if both arms move the same.
Exactly. Does the right arm move as much as the left? If not, maybe there's a fractured clavicle from a difficult delivery.
Ah, okay.
I'm looking at the chest wall dynamics. Is the chest rising easily, or are the muscles between the ribs actively sucking inward with every breath?
Which would mean they're struggling.
Showing me the lungs are stiff,
Uh-huh.
and I'm listening to the acoustic quality of their breathing. All that happens in the first 30 seconds just by watching.
Okay, let's take that observational data and start putting hard numbers to it. As we transition from looking to measuring, we hit the vital signs and anthropometry, the baseline metrics.
The foundation of the exam.
Right. And again, if you are a medical student used to adult medicine, these numbers are going to look terrifying.
They require a complete recalibration of your clinical instincts.
So true. Let's start with the respiratory rate. The normal parameter for a newborn is 30 to 60 breaths per minute.
Which is fast.
Yeah, if an adult is breathing 60 times a minute, you are calling a code blue. But the guidelines state this isn't just a quick 15-second count multiplied by 4.
No, and if you do that, you will fail the assessment.
Why?
Newborns have immature respiratory centers in their brainstem. They frequently exhibit something called periodic breathing.
Periodic breathing.
Yeah, where they might take rapid, shallow breaths for 10 seconds and then completely pause apnea for 5 to 10 seconds before starting again.
Oh, wow. So they just stop breathing for 10 seconds.
Exactly. So if you only count during a pause, you'll record a dangerously low rate.
And if you catch them in a rapid phase,
You'll document severe tachypnea. You must place your hand gently on their abdomen, because babies are diaphragmatic breathers, and count for 1 full, continuous minute to get an accurate average.
that makes total sense. The same applies to the heart rate.
Yep.
We mentioned earlier the target is 100 to 160 beats per minute. You check this epically.
Right.
I want to translate that for our listeners. You are placing the stethoscope directly over the apex of the heart, which in a newborn is located at the 5th intercostal space, right along the mid-clavicular line,
And you count that for a full minute as well, listening for the rhythm and any underlying murmurs.
which we'll dissect deeply in a few minutes.
Yes, we will.
The last vital sign is temperature. The goal is 36.5 to 37.5 degrees Celsius. The Stanford guidelines are very specific that the axillary route under the arm is the gold standard now.
Historically, rectal temperatures were standard to check core temp and simultaneously verify that the anus was open.
2 birds with 1 stone.
Right, but the risk of accidentally perforating the fragile mucosal lining of the rectum outweighs the benefit. We stick to axillary.
Good to know.
If it's low, under 36.5, you immediately consider 3 things. Is the room too cold? Is the baby's blood sugar crashing? Or, most dangerously, is this the first sign of neonatal sepsis?
Sepsis. But wouldn't they have a fever?
No, a newborn immune system doesn't mount a massive fever when infected like an adult does. They often get cold and lethargic.
Oh, wow. That's totally opposite to what you'd expect. Okay, after vitals, we take out the measuring tape. Anthropometry.
Getting the dimensions.
We record the birth weight, the length from the crown of the head to the heel using a rigid intentometer board, and the head circumference.
Pulling the tape over the most prominent part of the occiput in the back and just above the eyebrows in the front.
Because we need to know exactly how big the brain is. Normal is roughly 33 to 35.5 centimeters. But the absolute numbers are less important than the plot points, right?
Exactly. We map these measurements onto highly specific growth charts.
Like the WHO curves.
For a term baby, yes, we use the WHO curves. If it's a premature infant, we use a specialized tool like the Fenn growth chart, which adjusts for exactly how many weeks gestation they were.
So my instinct as a student would be, a big baby is a healthy, robust baby. But the sources actually flag the extremes on both ends as massive danger zones.
They absolutely are.
You categorize them as SGA small for gestational age,
Yeah.
below the 10th percentile, or LGA large for gestational age, above the 90th percentile. Why does being big put a baby at risk?
It's all about the intrauterine environment that caused them to get so big in the first place. LGA babies are frequently the product of maternal gestational diabetes.
Okay.
Think about the physiology. The mother's blood sugar is chronically high. That sugar crosses the placenta and floods the baby's bloodstream.
And the baby has to deal with it.
Right. The baby's pancreas responds by pumping out massive amounts of insulin to push that sugar into their cells.
Which acts as a growth hormone.
Exactly, making the baby large and storing massive amounts of fat.
Okay, so the baby is essentially living in a high-sugar environment and producing tons of insulin to match it.
And exactly. Now, the umbilical cord is cut. The constant supply of maternal sugar is instantly shut off.
But the baby's pancreas doesn't know that yet.
It has no idea. It is still pumping out huge surges of insulin. Within hours of birth, that excess insulin drives whatever little glucose the baby has left straight into the tissues.
Causing the blood sugar to just completely crash.
Catastrophically. Hypoglycemia in a newborn can lead to seizures and permanent brain damage. So an LGA baby looks robust, but their metabolic system is deeply unstable.
That is an incredible hidden danger. Now, what happens when you don't even know where to plot them on the chart because the gestational age is a complete mystery?
It happens more often than you'd think.
Let's say an unhoused patient comes into the ER, no prenatal care, and delivers a baby. The baby weighs 4 pounds. Is this a severely growth-restricted 40-week term infant, or is it a perfectly healthy 32-week premature infant?
The clinical pathway for those two scenarios is entirely different.
Completely different. So how do you know? This brings us to one of my absolute favorite clinical tools from the sources, the new Ballard score.
Oh, it is essentially forensic medicine for neonatology.
Forensic medicine, I love that.
By examining a series of very specific physical and neuromuscular traits, we can reliably deduce the baby's exact age in weeks, regardless of what the weight or the medical records say.
The Ballard score is split into two halves. Let's look at the neuromuscular maturity side first.
Sure.
The premise here is that as the central nervous system matures in the womb, the baby's muscle tone actively changes. We test 6 parameters: posture, the square window, arm recoil, the popliteal angle, the scarf sign, and the heel-to-ear test.
Let's visualize the biology of tone. In the second trimester, the descending motor pathways from the brain down to the spinal cord are completely unmyelinated.
Meaning they lack the fatty insulation needed to transmit strong signals.
Exactly. So a 28-week premature baby has very poor muscle tone. They lie flat on the warmer, their arms and legs fully extended and limp. Their joints have no resistance.
So if I do the scarf sign on that preemie, meaning I take their hand and gently pull their arm straight across their chest, like wrapping a scarf around their neck.
What happens?
The arm just keeps going.
Really?
It will wrap all the way around their neck without any resistance. The elbow easily crosses the midline of the chest.
Wow.
And if you do the heel-to-ear test, you can take their little foot and push it straight up to their ear, and the leg remains perfectly straight. They are practically made of rubber because there is no flexor tone fighting you.
But a 40-week full-term baby is a completely different story.
Entirely different. In the third trimester, as the brain matures, it sends constant, powerful signals to the flexor muscles. A term baby rests in a tight, curled-up fetal position.
If you try that scarf sign on a 40-weeker,
You will meet immediate active resistance. You won't even be able to pull their elbow past the midline of their chest.
and what about the square window test? If you bend their wrist forward, the square window test. A preemie's wrist is stiff and won't fold, but a term baby's wrist is incredibly flexible due to maternal relaxin hormones.
Oh, the relaxin transfers to the baby.
Yes. And the hand will fold completely flat against the forearm, making a 0-degree angle.
It's fascinating how you read the maturation of the brain through the resistance in the joints. The second half of the Ballard score evaluates physical maturity. This is looking at the actual tissues.
The skin is a perfect chronological map.
Tell me about that.
A 24-week preemie has skin that is translucent, sticky, and friable. You can literally see the blood vessels right underneath.
Because they haven't built up any fat yet.
Exactly. As they age, subcutaneous fat develops. A 40-week baby has thick, opaque skin.
And what if they go past term?
A post-term 42-week baby has been sitting in amniotic fluid too long without the protective coating of vernix.
So they get pruny.
Worse, their skin looks like they've been in a bathtub for 3 months. It's cracked, peeling, and leathery.
Oh, wow. We also look at lanugo, which is that fine, downy peach fuzz hair.
Lanugo is a brilliant evolutionary adaptation. It appears around 20 weeks gestation.
What's it for?
Its primary purpose is to act like Velcro. It holds the vernix caseosa, the thick, white, cheesy substance the baby secretes against the skin to protect it from the acidic amniotic fluid.
Okay, so the hair holds the protective cheese layer on. Got it.
As the baby reaches full term, the lanugo begins to thin and disappear. So if a baby is covered in a thick pelt of fine hair, they are likely premature. If they are mostly bald, they are closer to term.
The score also mandates checking the plantar surface, the soles of the feet.
Yes, a preemie's foot is completely smooth.
Oh, wow.
Yeah, and as they mature, creases start to appear from the top near the toes.
Kind of moving downward over time.
Exactly, until a term baby has these deep, complex creases over the entire sole.
You also assess the breast buds, checking the millimeter width of the actual glandular tissue beneath the nipple, and you check the ear cartilage.
The ear is a great quick check. The cartilage in the pinna doesn't stiffen until the very end of pregnancy.
So if you fold it,
If you take the top of the ear on a 30-week preemie and fold it down, it stays folded flat against the head. It has no spring.
and a term baby.
A 40-week term baby has thick cartilage. You fold the ear, and it instantly springs right back into place.
So you evaluate all these tiny clues, assign a score of -1 to 5 for each, add them up, and the total gives you a highly accurate gestational age. It's a masterclass in physical diagnosis.
It really is an incredible system.
All right, our student doctors have their baseline vitals, the measurements are plotted, and we know our patient's true age. It is time to initiate the physical head-to-toe examination.
Finally.
We start with the surface area, the skin. This is our canvas.
And as a neonatologist, your eyes have to be calibrated to ignore the noise.
What do you mean by noise?
The newborn skin is wildly reactive. It is transitioning from a sterile, wet environment to a dry environment filled with air, bacteria, and friction. It reacts to everything.
Oh, so it's constantly breaking out.
Exactly. Your job is to instantly differentiate between a terrifying-looking but completely benign transitional rash and a subtle spot that indicates a lethal underlying condition.
Let's decode the benign findings first, because parents will definitely ask you about them. The sources list milia. These are tiny, pearly white, pinhead-sized bumps, usually clustered on the nose, chin, and forehead. What are they biologically?
They're simply microscopic epidermal cysts.
Like baby acne.
Sort of. During the final weeks in the womb, the sebaceous glands on the face get stimulated by maternal hormones and overproduce keratin and oil, which gets trapped just under the surface.
Okay, so they look like tiny white heads, but they are completely sterile.
Right. No treatment is needed. As the top layer of skin naturally slacks off over the first few weeks, the trapped keratin escapes and they vanish.
Then there is erythema toxicum, which frankly has to be the worst named benign condition in medicine. It sounds like a radioactive poison.
It truly is a terrible name. Erythema toxicum neonatorum presents as small, flat, red patches with a tiny, raised, yellowish-white wheal in the center.
A classic description is that it looks like a flea bite, right?
Exactly. It often erupts on the chest, back, and face on day 2 or 3.
The parents are going to think the baby has a staph infection or an allergic reaction.
Exactly. But if you were to take a microscopic scraping of that little white center, you wouldn't find bacteria or pus. You would find an overwhelming concentration of eosinophils, which are a specific type of white blood cell involved in immune responses.
So the baby's immune system is just overreacting.
It is believed to be the baby's naive immune system aggressively overreacting to the sudden colonization of normal skin flora, the everyday bacteria that suddenly start living on their skin. The immune system freaks out, causes this harmless rash, figures out there's no actual danger, and it disappears in a week.
The guidelines also highlight Mongolian spots, though I think the more accurate clinical term now is congenital dermal melanocytosis, or slate gray nevy.
Yes. These are flat, smooth, bluish-gray or deep brown birthmarks, overwhelmingly found on the lower back, the sacrum, or the buttocks, predominantly in infants of Asian, African, or Hispanic descent.
Biologically, what's happening there?
During embryological development, melanocytes, the cells that produce pigment, migrate from the neural crest down into the epidermis. In these infants, a cluster of those cells gets stalled halfway, trapped deep in the dermal layer of the skin.
Ah, so they never make it to the top.
Right. Because the pigment is trapped deep down, the light scattering through the skin makes it look blue or gray, much like a tattoo.
And crucially, for the medical student, you absolutely must document these on day one.
You have to.
Because to an untrained eye in an emergency room 6 months later, a blue mark on the buttocks looks exactly like a bruise from child abuse. Documenting that it is a congenital melanocyte deposit protects the family.
Precisely. It is so important. Now, those are the harmless findings. Let's pivot to the red flags.
Okay. The sources list central cyanosis blueness of the lips and tongue, which indicates true systemic oxygen failure.
Right.
More than 10 skin pustules, which, unlike erythema toxicum, could indicate a true staphylococcal skin infection. And the massive red flag, jaundice within the first 24 hours of life.
This is a critical concept to unpack. Let's look at the biochemical mechanism. Jaundice is the yellowing of the skin and eyes caused by an accumulation of a pigment called bilirubin.
And bilirubin is the garbage byproduct of breaking down old red blood cells.
Exactly.
And babies have a lot of red blood cells to break down there.
Huge amounts. In the womb, oxygen tension is very low, so the fetus compensates by producing massive amounts of fetal hemoglobin to grab every molecule of oxygen it can.
So once they're born and breathing air, they don't need that massive surplus.
So their body starts aggressively destroying the extra red blood cells, producing huge amounts of bilirubin.
And it's the liver's job to filter that bilirubin out.
Right. The liver has to conjugate it, basically attach a sugar molecule to it so it can be excreted.
Right, in the school.
Exactly. But a newborn's liver is, it's immature, the enzymes are slow.
So the bilirubin just piles up.
On day 3 or 4, the bilirubin piles up in the blood faster than the liver can clear it, and the baby turns yellow. This is physiological jaundice. It is expected.
But the protocol explicitly states that jaundice appearing within the first 24 hours is a medical emergency. Why?
Because the liver, even an immature one, can handle the normal rate of cell breakdown for at least a day or two. If a baby turns visibly yellow at 12 hours of life, the bilirubin isn't just accumulating slowly, it is skyrocketing.
Something else is destroying the cells.
This tells us there is pathological accelerated destruction of red blood cells happening, usually because of a blood group incompatibility, like the mother being O negatives and the baby being A positive.
Oh.
The mother's immune antibodies have crossed the placenta and are actively destroying the baby's blood cells.
And why is high bilirubin dangerous? I mean, it's just a pigment, right?
Because unconjugated bilirubin is highly fat-soluble. If the levels get too high, the pigment crosses the blood-brain barrier and permanently stains the basal ganglia of the brain.
Permanently stains the brain.
Yes. This causes a devastating, irreversible neurological condition called kernicterus, resulting in cerebral palsy and hearing loss. Jaundice on day 1 demands immediate blood tests and intense phototherapy to break down the pigment.
Wow. Okay, moving from the skin up to the head. This is an area of intense anxiety for parents. They look at their beautiful baby, and the head looks like a stretched-out alien cone.
The cranial exam. To understand this, we have to talk about the engineering of the newborn skull.
Okay.
Unlike an adult skull, which is a solid helmet of fused bone, the newborn skull is made of several flat, bony plates connected by flexible fibrous seams called sutures.
And where these sutures intersect, you have large open spaces called fontanelles or soft spots.
Yes. The anterior fontanelle is diamond-shaped, sits right on top of the head, and remains open for over a year. The posterior fontanelle is smaller, triangular at the back of the head.
And the purpose of this design is twofold, according to the sources. First, it allows for the rapid expansion of the brain during the first year. Second, and most immediately, it allows the bony plates to physically slide over and overlap one another.
A process called molding.
Right, molding. So the skull can compress and fit through the narrow birth canal. That overlapping is what creates that temporary, elongated cone head appearance.
But sometimes it's not just the bone shifting. Sometimes there's actual swelling.
The clinical notes emphasize a mandatory exam question here. You must be able to differentiate between caput succedaneum and cephalohematoma.
Oh, this is a classic board question.
They're both lumps on the head. How do we tell them apart biologically?
This is all about anatomical layers. Let's start with caput succedaneum. During a long vaginal delivery, the baby's head is pressed hard against the mother's cervix. It acts like a vacuum cup.
Ouch.
Yeah, this pressure causes the skin and the loose subcutaneous tissue of the scalp to become highly edematous, filled with fluid swelling.
So it's essentially a bruise or fluid trapped in the outermost layer, the scalp tissue.
Exactly. And because the scalp tissue covers the entire head continuously, the swelling can spread anywhere. It freely crosses the suture lines between the bones.
Okay, so it crosses the
It
lines.
feels squishy, boggy, and it usually resolves harmlessly in a few days as the fluid is reabsorbed.
Now contrast that with a cephalohematoma.
A cephalohematoma is bleeding, but it is bleeding deeply trapped under a very specific layer. Every individual bone in the skull is wrapped tightly in a tough, fibrous membrane called the periosteum.
Think of the periosteum like tight saran wrap over a single skull bone.
That's a perfect analogy, saran wrap. If the shearing forces of labor rupture a tiny blood vessel beneath that saran wrap, the blood pools directly against the bone.
Because it's trapped under the saran wrap, the periosteum, it is physically tethered to the edges of that specific bone.
Exactly. It cannot cross the suture line to the next bone because the periosteum is glued down at the edges.
So you can feel the boundary.
So a cephalohematoma presents as a distinct, firm, water balloon-like swelling isolated over just one side of the head, usually the parietal bone. It takes weeks to resolve.
And as that trapped blood breaks down, it releases, you guessed it, more bilirubin, putting the baby at higher risk for severe jaundice.
It all connects.
That structural analogy clarifies it perfectly. The guidelines also briefly mention checking the shape to rule out craniosynostosis.
That is when one of those fibrous sutures fuses into solid bone prematurely while the baby's in the womb.
So the head can't grow properly.
Right. If the sagittal suture down the middle fuses early, the brain can't grow sideways, so it only grows front to back, creating a long, narrow, boat-shaped head. It requires neurosurgical intervention to unlock the skull and give the brain room to grow.
Let's move down to the face. The eyes, ears, nose, and mouth. For the eyes, we are assessing the sclera, checking for purulent discharge that might indicate a chlamydia or gonorrhea infection contracted in the birth canal.
Yes.
But the ultimate diagnostic tool here is the ophthalmoscope to check the red reflex.
This is the exact same optical physics that ruins flash photography. When you shine a bright light directly into the pupil, the light travels through the clear cornea, the clear lens, the clear vitreous fluid, hits the blood-rich retina at the back of the eye, and reflects back as a bright, symmetrical red-orange glow.
But the sources warn that a white reflex, called leukocoria, is a massive red flag. What physically causes the light to reflect back white instead of red?
It means the optical pathway is blocked by something opaque. The two most terrifying causes in a newborn are a congenital cataract, where the lens itself is cloudy and white, or retinoblastoma.
Retinoblastoma, that's cancer, right?
Yes, retinoblastoma is a highly aggressive, malignant cancer of the retina. The tumor grows inside the globe of the eye, completely blocking the red reflection. Finding a white reflex on day one requires an immediate emergency pediatric ophthalmology consult to save the eye and potentially the child's life.
That is heavy. Moving to the ears, we're looking at placement. You mentally draw a horizontal line from the outer corner of the eye, the canthus, straight back toward the ear.
And the very top of the pinna should touch or cross above that line.
We assess the cartilage spring, as we discussed in the Ballard score, but we are also hunting for tiny anomalies. Preauricular pits, which look like tiny pinholes in front of the ear, or skin tags.
Yes, very important to note.
My instinct is, it's just a cosmetic skin tag, who cares? Why do the protocols demand we investigate a tiny skin tag?
Because in embryology, timing and location are everything. During the first trimester, the embryonic arches that fold together to form the external ear structures are forming at the exact same time and from the same foundational tissue as the structures of the inner ear and the kidneys.
The kidneys?
Yes. If a genetic glitch or an environmental stressor caused a structural defect in the external ear, leaving a pit or a tag, there's a statistically significant chance that the same glitch affected the inner ear, causing hearing loss, or the kidneys, causing renal malformations.
That interconnectedness is wild. So you use the external anomaly as a flag to order a hearing screen and potentially a renal ultrasound.
Exactly, it's a clue.
For the nose, you highlighted a vital anatomical fact from the literature. Babies are obligate nasal breathers.
This is a fundamental survival mechanism. Think about the mechanics of breastfeeding. The infant has to remain attached to the breast, vigorously sucking and swallowing fluid for 20 minutes at a time.
If they had to stop and breathe through their mouth, they would choke or suffocate.
Right. Neurologically and anatomically, their epiglottis and soft palate are configured to create a watertight seal for swallowing while allowing continuous airflow through the nasal passages.
So they literally cannot mouth breathe to compensate if their nose is blocked.
For the first few months of life, a blocked nose is a blocked airway, period. Therefore, the physical exam must verify the patency of both nostrils.
How do you do that?
You can hold a cold stethoscope bell under the nose and look for fogging, or gently occlude one nostril and ensure they can still breathe quietly. We are actively ruling out choanal atresia.
Which is what?
It is a congenital condition where a solid plate of bone blocks the back of the nasal passage. If a baby has bilateral choanal atresia, they will turn deep blue and suffocate the moment they stop crying and close their mouth.
Wow. Which brings us down to the mouth. We're looking for a clean oral cavity. You run a gloved finger along the roof to ensure the hard and soft palates are fully fused with no hidden clefts.
You check that the uvula is midline. You might see Epstein pearls, which are completely benign little white cysts of trapped epithelial tissue on the gums.
And critically, while your finger's in there, you're feeling for the strength of their suck and gag reflexes.
Are the cranial nerves that control the tongue and pharynx fully intact? Can they safely swallow?
We're building an incredibly detailed picture here. Let's transition from the airway of the nose and mouth straight down the trachea into section 4. The chest, lungs, and heart.
The engine room.
We already touched on the normal respiratory rate of 30 to 60, but the Stat Pearls reviews dedicate significant space to the visual signs of work of breathing. When the lungs are failing, what does it physically look and sound like?
The physical manifestations of respiratory distress are the body utilizing desperate compensatory mechanisms to keep the alveoli, the tiny air sacs, open.
Let's start with the face.
First, look at the nose, nasal flaring. The nostrils flare wide open with every inhalation. By increasing the diameter of the nasal airway, they are utilizing fluid dynamics to drastically decrease airway resistance, trying to suck in more volume.
And what about the chest?
Second, look at the chest wall. The newborn rib cage is highly cartilaginous. It is very soft and compliant.
So if the lungs inside are stiff, maybe they lack surfactant, or they are still full of fluid, the diaphragm has to pull down incredibly hard to try to inflate them.
Exactly. And because the lungs won't easily expand, that massive negative pressure generated by the diaphragm ends up sucking the soft chest wall itself inward. We call these retractions.
So you will visually see the skin and muscle pulling deeply inward between the ribs, under the rib cage, and at the sternum with every single breath.
It looks exhausting, because it is.
And then there's the auditory component, grunting.
Grunting is perhaps the most brilliant and desperate physiological hack a newborn has. When an infant has stiff lungs, the alveoli want to collapse entirely at the end of every exhalation.
And if they collapse, it takes massive energy to pry them open again for the next breath.
So the baby adapts. As they exhale, they intentionally clamp their vocal cords partially shut. They are forcing the exhaled air against a narrow opening, creating a back pressure down into the lungs.
Like putting your thumb over the end of a garden hose.
Yes, that back pressure is called autopeep, positive end expiratory pressure. That pressure physically splints the alveoli open at the end of the breath.
And the sound.
The acoustic sound of the air forcing its way past the vocal cords is the grunt. If you hear a baby grunting on the warmer, they are doing everything in their power to keep their lungs from collapsing. They will tire out and they will need respiratory support.
Let's move an inch to the left to the cardiovascular exam. The heart. We place our stethoscope apically. We want to hear that rapid, regular rhythm of 100 to 160 beats.
Right.
But the sources note that neonatal heart murmurs on the first day of life are incredibly common and often transient. A murmur is just the sound of turbulent blood flow. Given that the entire plumbing system is rerouting, it makes sense we'd hear some turbulence.
In fetal circulation, the blood bypasses the non-functioning lungs using two shunts: the foramen ovale, a hole between the upper chambers of the heart, and the ductus arteriosus, a vessel connecting the pulmonary artery directly to the aorta.
And when the baby takes its first breath,
Pulmonary resistance drops, pressure in the left heart rises, and the foramen ovale functionally slams shut. Over the next 24 hours, the ductus arteriosus constricts and closes due to rising oxygen levels and a drop in maternal prostaglandins.
so while those doors are closing, blood might squeeze through narrow gaps, causing a temporary whooshing sound, a murmur.
Exactly.
But the clinical warning is clear. We cannot blindly dismiss a murmur as transitional. It must be investigated if it's accompanied by poor perfusion, central cyanosis, or abnormal pulses.
Assessing perfusion is critical. We test capillary refill time.
How does that work?
You press firmly on the baby's sternum or heel to blanch the blood out of the skin, release it, and count how many seconds it takes for the pink color to return. It should be less than 3 seconds.
If it takes 5 seconds, the heart is failing to push blood effectively to the skin.
Then you must palpate the pulses. Every medical student must learn to simultaneously feel the right brachial pulse in the arm and the femoral pulses deep in the groin.
The Stat Pearls review specifically highlights that weak or absent femoral pulses are a pathognomonic clue for coarctation of the aorta. Let's explore the anatomy of that.
The aorta is the massive main pipe carrying oxygenated blood from the heart to the entire body. It arches up, gives off branch pipes to the arms and head, and then curves downward to supply the abdomen and legs.
Okay, so it goes up, branches off, then goes down.
Right. A coarctation is a severe congenital pinching or narrowing of the descending part of that pipe.
So the branches to the arms are before the pinch, but the pathway to the legs is after the pinch.
Exactly. The arms and the head get plenty of blood at very high pressure, so the brachial pulses feel strong and bounding. But the lower body is starved.
Because the blood flow is choked off at the narrowing.
So if you feel the groin, the femoral pulses are weak, delayed, or completely absent. The legs might feel cool to the touch. This baby is in impending heart failure and needs immediate prostaglandins to force that ductus arteriosus back open to bypass the pinch, and an urgent echocardiogram.
This seamlessly transitions into one of the most critical, life-saving protocols in our stack today. The Critical Congenital Heart Disease, or CCHD, pulse oximetry screening protocol established by Newborn Screening Ontario.
It is arguably one of the most effective, non-invasive public health screening tools developed in the last 2 decades. It catches lethal structural heart defects before the baby ever looks sick.
The protocol states this is an asymptomatic screen. You do it on babies who look perfectly pink and healthy. The timing is very precise. It must be done optimally between 24 and 36 hours of life, but acceptable up to 48 hours. Why can't we just do it at hour 2 and send them home?
Because of that transitional plumbing we just discussed, at 2 hours of life, it is totally normal for the ductus arteriosus to still be partially open, allowing some unoxygenated blood to mix into the systemic circulation.
Oh, so their oxygen saturations might normally hover in the low 90s anyway?
Exactly. If we screened at hour 2, we would have a massive, unmanageable failure rate of false positives. By 24 hours, the normal physiological transition should be complete, the doors should be shut tight, and a healthy baby's oxygen saturation should be a rock-solid 95% to 100%.
Here is the actual methodology. The protocol outlines a very precise technique. You use a motion-tolerant pulse oximeter wrapped around the skin. You must place the probe on the right hand, which is designated as preductal, and then on either foot, which is designated as postductal.
Is this crucial?
I'm going to pause right here and demand a deeper explanation. Why is the right hand specifically preductal? Why doesn't the left hand work?
This is one of my favorite anatomical quirks. To visualize this, picture the arch of the aorta again. The blood leaves the heart and hits the arch. The very first branch that comes off that arch is the brachiocephalic artery, which splits to supply the right side of the brain and the right arm.
Okay, the first exit off the highway goes to the right arm.
Yes. Now, further down the arch, after that first exit, is where the ductus arteriosus connects the pulmonary system to the aorta.
Ah.
So if there is a severe heart defect causing poorly oxygenated blue blood to bypass the lungs and shoot through the ductus into the aorta, that blue blood enters the highway after the exit for the right arm.
Mind blown. So the right hand is receiving pure oxygenated blood directly from the heart before any mixing can possibly occur. It is the truest representation of what the brain is getting. That's why it's preductal.
You've got it. The left arm exit is variable. Sometimes it's before the ductus, sometimes it's right on top of it. We can't trust it.
But the exit for the lower body and the feet
Is definitively after the ductus. It is postductal. So we measure the right hand, and we measure a foot, and we compare them.
If the plumbing is normal, both should read high, 95 to 100%. But if there's a massive ductal shunt caused by a hidden heart defect, the foot will be starved of oxygen compared to the right hand. The algorithm from Newborn Screening Ontario gives us 3 strict action paths based on these 2 numbers. First is a pass, or screen negative. This requires the oxygen saturation to be 95% or higher in the right hand or foot. And D, the absolute difference between the hand and the foot must be 3% or less.
Action. The baby is cleared. No further screening required.
Second is a repeat. This is triggered if the saturation is anywhere between 90% and 94% in either extremity, or if the difference between hand and foot is 4% or more.
Action. You don't panic, but you repeat the screen in exactly 1 hour. You can do this up to twice.
Third is a refer, or screen positive. This happens immediately if the saturation is less than 90% in either extremity at any time, or if they continue to fail the repeats.
Action. Urgent physician assessment, oxygen, and an immediate echocardiogram to visualize the heart structure.
It's pure physics and anatomy applied as a simple algorithm.
It consistently catches ductal-dependent lesions like hypoplastic left heart syndrome, where the left side of the heart didn't grow, or transposition of the great arteries, where the main pipes are plumbed backwards, often hours before the baby crashes and goes into shock.
All right, taking a deep breath of our own. We're moving down the body to section 5, the abdomen, genitalia, and spine. Let's look at the belly. A normal newborn abdomen is slightly protuberant, a little bit of a pot belly.
Yes, their abdominal musculature is underdeveloped, and their liver is relatively huge compared to their body size, pushing everything outward.
What you absolutely do not want to see is a scaphoid abdomen, one that is sunken in looking completely hollow and empty.
No, you do not want to see that.
The sources flag a scaphoid abdomen as a high alert warning for a congenital diaphragmatic hernia. What happens during development to cause that?
In early embryology, the diaphragm forms to create a solid muscular wall, sealing off the chest cavity from the abdominal cavity. In a diaphragmatic hernia, that muscle fails to close completely, leaving a hole.
And then what?
As the fetus grows, the intestines, the stomach, and sometimes the liver migrate up through that hole into the chest cavity. The abdomen looks hollow and scaphoid because it is empty. The organs aren't there.
And the true danger isn't just misplaced intestines, it's the lungs.
Right. Because those abdominal organs spent months growing inside the tight space of the chest, they physically crush the developing lungs. The lungs are hypoplastic, severely underdeveloped.
So when this baby is born,
They will immediately go into catastrophic respiratory failure. You never, ever use a bag mask to ventilate a baby with a suspected diaphragmatic hernia.
great, why not?
Because pumping air with the mask will inadvertently pump air down the esophagus and inflate the stomach and intestines that are sitting in the chest.
Oh, God.
They will expand like balloons, further crushing whatever tiny bit of lung tissue the baby has left. They must be intubated immediately with a tube straight into the trachea.
Incredible. Moving to the umbilicus, the belly button, the cord stump is clamped. We examine the cut end to confirm the presence of exactly 3 blood vessels. I learned the mnemonic AVA artery, vein artery, 2 small, thick-walled arteries, and 1 larger floppy vein.
It seems counterintuitive to adult anatomy, but in the umbilical cord, the single vein carries the freshly oxygenated blood from the placenta to the baby.
And the 2 arteries pump the deoxygenated waste blood back to the placenta.
Finding only 2 vessels, a single umbilical artery, can be an isolated benign finding, but it is statistically linked to renal anomalies and genetic syndromes, so it prompts a closer ultrasound of the baby's kidneys.
You also gently palpate the abdomen, feeling for hepatosplenomegaly, making sure the liver and spleen aren't massively enlarged.
Which is a classic hallmark of congenital infections like cytomegalovirus or toxoplasmosis.
From the abdomen, we move down to the genitalia. This is an area where parents lack experience and often have high anxiety about what is normal.
For term females, the sources emphasize that the labia majora are normally quite prominent and swollen. And, critically, parents might notice a thick white vaginal discharge, or even a few drops of actual blood in the diaper on day 2 or 3.
To a parent, seeing blood in a newborn's diaper is terrifying. But you explain this is completely physiological.
It is called pseudomenstruation. Think about the endocrine environment of the womb. For 9 months, the baby is swimming in the mother's exceedingly high levels of estrogen and progesterone.
And those hormones cross the placenta.
Yes, and stimulate the baby's own endometrial tissue, the lining of the microscopic uterus. When the cord is cut, the maternal hormone supply abruptly ends.
So it's withdrawal.
As the estrogen levels in the baby's blood crash over the first 48 hours, that withdrawal triggers the shedding of the uterine lining, just like a normal menstrual cycle. It is entirely benign, requires no treatment, and resolves in a few days.
For male infants, the physical check involves ensuring both tests have descended from the abdomen down into the scrotum. We look for deep rugae, or wrinkles, on the scrotal sac, which the Ballard score taught us is a sign of term maturity.
And we must meticulously inspect the glands of the penis to confirm the location of the urethral opening.
We want to see the opening dead center at the tip of the glands. If the opening is located anywhere on the ventral side, the underside of the penile shaft, that is a condition called hypospadias.
It is a failure of the urethral folds to close completely during development.
And the immediate clinical action item for a student seeing hypospadias is cancel the circumcision.
Absolutely. The baby must be evaluated by a pediatric urologist before any tissue is removed. Often the surgeon needs to preserve the prepuce, the foreskin, to use as grafting tissue to surgically reconstruct the urethra later in infancy.
We also have to confirm plumbing patency at the other end. The anal opening. The notes stress visualizing a patent anus and verifying the timeline of output.
Imperforant anus is a spectrum of malformations where the rectum fails to connect to the outside world. It might end in a blind pouch, or it might incorrectly fistula into the urinary tract.
The timeline is your failsafe, right?
Yes. A healthy newborn is expected to pass meconium, that thick, dark green, tar-like first stool made of swallowed amniotic fluid and cellular debris, within 24 to 48 hours. They must pass urine within 48 hours.
If the diaper is dry or empty after 2 days, the plumbing is either obstructed or the kidneys and bowels are failing.
Exactly.
To complete the trunk exam, we carefully turn the baby over into a prone position to examine the back and spine. You run your fingers down the vertebral column, feeling for a normal contour, but you are specifically hunting for cutaneous markers at the very base of the spine near the gluteal cleft.
Things like sacral dimples, tufts of hair, or skin tags.
Why does a patch of hair on the lower back alarm a neonatologist?
Because of the embryological connection between the skin and the nervous system. In the first few weeks of gestation, a structure called the neural tube folds inward and zips shut.
Okay, the neural tube.
The inside of the tube becomes the spinal cord, and the outside layer of ectoderm heals over it to become the skin. If there is a microscopic defect in how the bottom of that tube zipped shut, it often leaves a clue on the surface of the skin.
So the skin is basically telling on the spinal cord below it.
Exactly. A simple, shallow, blind-ending dimple low down within the crease of the buttocks is incredibly common and usually benign.
But what if it's deep?
A deep pit, a dimple located higher up above the crease, or an abnormal tuft of hair is a classic cutaneous marker for occult spinal dysraphism.
Meaning?
This means there is a hidden defect, like a tethered spinal cord that is stuck to the bone, or a hidden spina bifida. If we see those markers, we order a stat spinal ultrasound to look beneath the skin before the baby ever tries to walk.
We are nearing the end of our physical assessment. Section 6, extremities and the hips. For the limbs, we ensure symmetrical movement. We do a hard count of the digits, 10 fingers, 10 toes.
We are checking for polydactyly, which is extra digits, often a tiny vestigial nub near the pinky, or syndactyly, the webbing or fusing of fingers or toes.
The guidelines also instruct looking closely at the palm of the hands for a single palmar crease.
If you look at your own palm, you likely have two main transverse creases running horizontally across the center. During early fetal development, as the hand forms and flexes, those distinct creases develop.
But in some cases.
However, in about half of infants with trisomy 21 Down syndrome, the hand development is altered, resulting in a single, straight, unbroken crease running entirely across the palm.
So while it can exist in genetically typical individuals, finding it prompts a thorough assessment for other dysmorphic features.
Exactly. It's just another clue to investigate.
Now we arrive at the musculoskeletal climax of the exam, the hip exam, the Barlow and Ortolani maneuvers. When I first read about these, they sounded like aggressive chiropractic adjustments.
They're really not.
The goal is to screen for developmental dysplasia of the hip, or DDH. So let's break down the mechanics. What exactly is wrong with a dysplastic hip?
Let's use a visual metaphor. Picture a classic action figure. The leg is attached to the pelvis by a round plastic ball sitting inside a hollow cup.
Real.
In a healthy baby, that cup, the acetabulum, is deep, and the ball of the femur sits tightly inside it, held by strong ligaments. In developmental dysplasia of the hip, the cup didn't form deeply enough. It's shallow, like a saucer instead of a cup.
And the ligaments are loose?
Because the cup is shallow, the ball of the femur can easily slide right out the back of the joint.
And if left undiagnosed, when that child stands up and puts weight on it to walk, the hip will permanently dislocate, causing a severe limp and lifelong arthritis.
Precisely. So we do two physical maneuvers to test the depth of the cup and the tightness of the joint.
First is the Barlow maneuver.
This is the dislocation test. You lay the baby on their back, flex their knees and hips up to 90 degrees. You grasp the thigh, bring the knee inward toward the midline, which is adduction, and you apply gentle but firm pressure backward, pushing down toward the mattress.
You are actively trying to see if you can push that ball out of the shallow saucer.
Yes, you are testing to see if the joint is unstable enough to be pushed out.
And if it slides out, you move immediately to the second test, the Ortolani maneuver.
This is the relocation test. You take that same flexed hip and you slowly abduct it. You open the leg outward, dropping the knee toward the table like opening a book.
Right.
At the same time, your fingers are behind the hip joint, lifting upwards. You are trying to slide that dislocated ball back over the rim and down into the saucer.
The text highlights an incredibly specific sensory detail here. You are not listening for a click.
Newborn ligaments are saturated with maternal relaxin hormones. They're loose. When you move their hips, you will constantly feel and hear soft, high-pitched clicks from tendons snapping over bones. Clicks mean nothing.
So what are we looking for?
What you are feeling for is a distinct, deep, palpable clunk.
Like the physical sensation of the action figure's legs snapping back into the socket.
Exactly. The clunk is the physical impact of the femoral head jumping over the bony ridge of the pelvis as it dislocates or relocates. A positive clunk is a hard stop.
And what's the next step if you feel it?
It requires an immediate referral to pediatric orthopedics and a hip ultrasound to secure the joint in a harness while the cartilage hardens over the first few months of life.
That brings us to the final act, Section 7, Neurological Assessment and Reflexes. The baby has been handled, their hips have been manipulated, they are likely awake, active, and thoroughly annoyed with us. This is the perfect baseline for the neuro exam.
The best time to do it.
The guidelines outline 4 pillars for the neurologic evaluation: muscle tone, joint mobility, body movements, and finally, the primitive reflexes.
The primitive reflexes are the undisputed star of the neurological show. They offer a direct, unmediated window into the baby's brainstem.
To understand these, we have to recognize that a newborn's brain is incredibly underdeveloped. The higher processing centers, the cerebral cortex, the part of the brain responsible for voluntary thought and intentional movement, are largely offline at birth.
They are not fully myelinated. If a newborn relied on their cortex to figure out how to survive, they would starve to death on day 1.
So, to keep the organism alive while the cortex matures, mammalian evolution pre-programmed the primitive lower brain, the brainstem, and the spinal cord with a suite of hardwired, automatic survival reflexes.
Built-in diagnostic software.
Let's run through it. First, the feeding reflexes. Rooting. If you gently stroke the corner of the baby's cheek, they instantly turn their head toward the touch, open their mouth wide, and drop their tongue.
This ensures that if they brush against the mother's breast, they automatically seek the nipple without having to learn how. This lasts about 4 months.
Sucking. If you touch the roof of their palate, they immediately engage in a coordinated, rhythmic suck-swallow-breathe pattern.
This reflex is fully developed by 36 weeks gestation, which is why babies born earlier than that often need feeding tubes.
Those are non-negotiables for immediate caloric intake. Then we test the defensive and postural reflexes. The most dramatic is the Moro reflex, often called the startle reflex. If you hold the baby slightly elevated and let their head safely drop backward a few inches, or if there is a loud, sudden noise, the baby executes a highly specific pattern.
They suddenly extend their arms outward, fan their fingers wide open, and then quickly bring their arms back tightly across their chest in a hugging motion, usually accompanied by a sharp cry.
Evolutionary biologists believe the Moro reflex is an ancient primate holdover. Imagine an infant macaque monkey riding on its mother's chest through the trees. If it slips and begins to fall, that sudden explosive spreading of the arms and rapid clutching inward, it's a desperate, hardwired attempt to grab hold of the mother's fur to stop the fall.
We test it to ensure the sensory input of falling instantly connects to a symmetrical motor output. If one arm doesn't move, we suspect a brachial plexus nerve injury from birth.
That evolutionary context makes it so much more than just a weird parlor trick. We also check the tonic neck reflex, often called the fencing posture. If the baby is lying flat and you turn their head to the right, their right arm will shoot out straight like they are holding a sword, and their left arm will bend up at the elbow.
It's fascinating to watch.
Then we test grasp and movement. Palmar and plantar grasp. You place your finger in their palm or press the sole of their foot, and their digits tightly curl and lock around your finger. Again, essential for gripping fur in our ancestors.
The stepping or dance reflex. If you hold a newborn upright, supporting their weight so the soles of their feet touch a solid table, they will alternate picking up their feet, looking exactly like they are trying to walk. This incredible hardwired motor pattern disappears around 2 months.
And we evaluate the spinal tracts with the Babinski reflex. If you take a firm object and stroke the outer sole of the foot from the heel up toward the toes, the big toe will bend backward and the other toes will fan out.
Now, I know from adult medicine that a positive Babinski sign is a terrifying finding. If you stroke an adult's foot and their toes flare upward, it means they have a severe upper motor neuron lesion like a stroke or a severed spinal cord.
It is deeply pathological in an adult.
Hmm.
But in a newborn, it is completely normal and expected up to about 1 year of age. Why?
Because the descending motor pathways from the brain, which normally suppress that upward flare, haven't finished myelinating yet. The connection is still under construction.
Which brings us to your critical expert insight from the notes. These reflexes tell us the brainstem works on day 1. But you argue that watching them disappear is actually the most important neurological test of the first year of life. Why?
Because it proves the higher brain is coming online. As the baby grows over those first 6 to 12 months, the cerebral cortex rapidly matures. It begins to assert dominance.
So the cortex takes over.
Yes. The cortex wants to execute intentional voluntary movements like reaching for a toy. To do that, the cortex must actively suppress and override the primitive, hardwired reflexes of the brainstem.
So if a baby still has a strong morostartle reflex or a rooting reflex at 8 or 9 months old,
It is a massive, blaring red flag. It tells us the diagnostic software failed to uninstall. The cortex has failed to mature and take control of the lower brain. It is one of the earliest and most reliable indicators of severe neurodevelopmental delays, such as cerebral palsy.
it's an evolutionary failsafe that we can use as a developmental timeline. We have just completed an incredibly exhaustive tour of neonatal physiology.
It's been a long shift.
We started with the first breath, evaluated the APGAR, plotted the anthropometry, mapped the gestational age with the Ballard score, translated the benign rashes, differentiated the cranial swelling, secured the airway, decoded the murmurs, verified the plumbing, tested the hips, and stimulated the brainstem.
A full day's work.
To synthesize this massive data set, the standard clinical approach is summarized as ask, check, look, listen, feel. And through every step of that sequence, we are vigilantly screening for the undeniable danger signs. A baby that is not feeding, an unstable core temperature, a respiratory rate blazing past 60, the audible grunt of collapsing lungs, jaundice appearing on day 1, absent femoral pulses, and a neurological tone that is either completely limp or rigidly stiff.
As we conclude these rounds, I want you to step back from the checkboxes and the scoring systems. I want to leave you, our medical student for the day, with a final perspective to carry into your career.
Go for it.
We have spent this entire deep dive hyper-focused on finding pathology. We have been hunting for the invisible clunks in the hip socket, listening for the turbulent murmurs of a failing heart, and watching for the desperate retractions of stiff lungs. It is easy to view the newborn as an incredibly fragile, precarious entity teetering on the edge of failure.
Very true.
But I want you to reframe that. I want you to consider the profound, violent resilience of the newborn body. Every single primitive reflex that perfectly executes without prior training. The immediate, massive physiological shift from fluid-filled lungs to a high-efficiency air-breathing system. The instant, pressure-driven rerouting of the entire cardiovascular plumbing to bypass the placenta and activate the pulmonary circuit.
Just staggering.
It's an evolutionary masterpiece of survival engineering. The next time you wash your hands, step up to that warmer and look down at a 2-hour-old infant. Do not just see a helpless, fragile baby waiting for a diagnosis. Look closely and see the incredibly complex, perfectly calibrated survival machine hiding in plain sight, executing millions of adaptations a minute to stay alive in a hostile new world.
Then ask yourself, how completely might our approach to adult medicine change if we viewed every single patient in our care as possessing this exact same inherent, fierce biological drive to survive?
That completely changes how I view the vulnerability of a patient. From the terrifying, murky transition of the first breath to recognizing the newborn as the ultimate calibrated survival engine. Thank you for joining us on these deep dive rounds today, and keep learning.